Okay, thank you. I think it's not working. It's working? Okay. We are in emergency. I think we have some technical problem. It happened all the day. I don't have any conflict of interest. And at the last topic of this session, we discussed something about guiding procedure in emergency. And I think that is a new standard in our life. We try all the day to avoid our error in practice because they appear, and also to reduce the rate of complication. Where we can use, because we can use when we put an IV line, sometimes it's very hard to obtain, to put a bladder probe to mounting and to drain collection, or to identify or guide our body, foreign body extraction. It's important to have another eye and to see what happened in this case. The ultrasound show us to see anatomical structure, to choose of devices, to choose a path that does not intersect as a vessel, nerve, or a tumor, to real-time visualization of the structure, and also to avoid technical complication. And sometimes in our daily life, we want to optimize the success of the technique, and also to improve our difficult approach, and to reduce our different risk to bleeding or for anatomical changes. What is important for us? We need to know the technique. We need to maintain the section. It's not all the time easy. We need to have a proper orientation of the probe and to keep it, because in other hand we go to right and the image go to left. We need to have training for these guiding procedures, and also to know our instruments and to handle it. Regarding the clinical context, we need to know the clinical history. We need to find our image aspects of the lesion, and also the risk assessment. What happened in terms of guidelines? Many societies recommend us to use ultrasound-guided peripheral vascular approach. It's a society for emergency physician, for sonography, or also the Society for Hospital Medicine, and they recommend us to be familiar with this operation, to use different transducers and to select them for guided procedures, and also how to use these guiding procedures for different blood vessel size. We have also the recommendation of FSUM guideline. The first recommendation is to identify the image of vessel who can be accessed. The second recommendation is to use for central venous access, and the third recommendation is to use real-time ultrasound guidance for case of difficult condition for cannulation. Why it's recommended for venous and arterial access? Because the technique is more safety, and maybe we decrease the number of passages, or in daily life we need one passage for obtain a vein, to increase the success rate, and also in difficult condition when we have a patient in cardiorespiratory arrest or vascular depletion, and we don't have the classical border for access. To see anatomical abnormality, and also to see something which is different from anatomical. We have the vein before the artery, if it's in laterally position, to avoid arterial puncture or pain tissue infiltration, and also to see if we have a post-insertion early catheter thrombosis and don't enter into a thrombosis vein, and to reduce the patient discomfort and uncomfortable position for vein exposure. What about information? We can see anatomical abnormality, we can see the artery-vein relation, or we can see if the vein has valve. We see the valve, we can help to pass through the valve if the catheter don't go between them. And also we can see the atheroma plaque at the level of artery. We know that in practice sometimes this happens to entry into an artery, after that go a little exit and the entry in the vein. But if we entry in an arterial plaque, it's a risk for embolism. We can see also the vessel diameter and choose a proper catheter for this. We can see the degree of collapse with inspiration and also improve our technique to have the vessel patterned. We can see the thrombosis of the vein and avoid this type of veins, the turbulent flow, and also the perivascular lymphadenopathy, which is a source of cannulation failure. What are criteria for peripheral venous cannulation? Skin marks difficult to identify, or we have an obese patient, a local edema, and we can't palpate the vein. We know that patient has vascular abnormality and we want to repair the vein. Maybe the patient has uncorrected coagulopathy. It happens sometimes in emergency, and you want to see where the vein is and to enter directly into the vein and limit the bleeding. Also, you have limited location on board, other catheter, local surgery, or the patient has a local infection and the space for the access is very short. And there is some cases in which you can anticipate difficulty to obtain an IV access because the patient has more than 3 punctures on one location, has 2 sites tested and failure to gain access. Sometimes it's important to know the history of the patient because if he has preview complication, it's better to guide the IV access. And also it's hard to obtain an IV access in patient in hypotension and shock and patient in cardiac arrest. In this case, ultrasound can help you to repair a vein and to obtain an access. How can you guide? It's many techniques. You can approach which you want. You can only make a blind technique to identify the vein and obtain the direction, and after that you do it without ultrasound, or you can use a real-time cross-section or the real-time longitudinal section. It's a little hard to stay in longitudinal position in one vein. It's more easy to use cross-section, but in cross-section you don't see the needle all the time in the real life. And you can combine real-time cross-sectional and followed by longitudinal section to see how you enter in the vein. You can also optimize your approach. In some cases, you can I hope it's working. In normal life, you use only one tourniquet, but if you don't have a good approach, you can use 2 tourniquets to increase the diameter of the vein and to see what happened. Do you see here when you enter with a catheter in the vein? I see here the catheter. You see that it's hard to stay all the time and to keep the vein in the longitudinal position. You see the progress of the catheter, and after that we can probe if the catheter it's into the vein or not, and we make a flash of saline solution. Here you see the saline solution which entry in the vein. We can also use ultrasound to assist the catheter because it's important part of our practice. We can see phlebitis of the catheter, and in this case it's an indication to exit with the catheter. We can see thrombosis at the level of catheter and maybe some floating thromb, which is not good for the patient. We can see inflammation of the tissue around, or maybe our catheter is not in the proper position after time, or the vein is completely thrombosis. Another application is to guide the bladder catheterization. We can see the introduction and also the bladder catheter control and permeability. First, we see what is the aspect of the bladder, if we have some clots or tumor, or if we have some problem into the bladder. We can evaluate the volume, and we can see the intravesical probe from balloon inflation on the bladder view after evacuation. How can we perform? First, we see the bladder. We see the presence of the urethral jet. We introduce the probe, and after that, we just looking if the probe is into, and we inflate the balloon, and we have the catheter into the bladder. And after that, we check the volume evacuation and also review the aspects of the bladder. It's important to avoid incidents in this case. We can inflate the balloon into urethra. It's not good for the patient. Maybe we have into the bladder the sound, but here that it's blocked because we don't evacuate the bladder and we need to do something. Or maybe the bladder is perforating and balloon appear in a supraperitoneal space. We have another indication to guide it, our nasogastric tube, and it's very easy to see in 3 positions. We can see in the neck position is near the trachea, and we can see here the tube. We can see at the level of epigastrum, and also we can see the tube into the gastric contain. Also, we use ultrasound to drain our pleural collection, and it's important to see also pulmonary re-expansion and efficient ventilation. And it's important for us to know before make a thoracocentesis what is the amount of collection, what is the functional impact, and also if we have or not aerial bronchogramma for the lung. In this case, it's also important to see if we have an ascendant diaphragm, if it's atelectasis associated, or if we have a pneumonic block and it's not a collection and don't puncture. In case of polytrauma patient, it's important to avoid fracture fault, to avoid vascular puncture, and also to see dynamic monitor of the aspects, because if we have a clear collection, it's okay, but if it's a collection with many other problems, we have to drain in a surgical way. It's very easy. We have the same algorithm to put the patient in orthopneic position, to monitor the vital sign, to prepare sterile the material, and to view the aspect of collection and mark the intercostal space where the collection is deep. We need to have more than 1 centimeter in inspiration to avoid puncture of the lung. We need to remember that the fluid moves with the patient, and put the patient in orthopneic position, give us the position in which we can make the drainage. If the patient has increased muscle mass or thick subcutaneous tissue, we can use curvilinear probe. And we need to clearly identify the lung parenchyma, the pleural fluid, and the diaphragm. It's important to know what is the superior and inferior border of the fluid collection, and we can use ultrasound in dynamic manner to see where we make the puncture. And when we perform thoracocentesis, it's being performed under dynamic real-time ultrasound guidance. Why? Because we can see the drainage, and we can see what happened with collection. And when collection is drained, we exit with the drain, and we can see also air into the remain collection. This direct visualization of the needle offers us the possibility to see what happened with the patient. Another way, post-drainage aspect is very important for us because we see that the volume is reduced. We can see, like I say, the air artifacts because when we make the puncture, we introduce a little quantity of air. And also we can see after that the small atelectatic area, and also we have to monitor the lung expansion because that is our target, to have a lung which ventilate. There is another application for pericardiocentesis. It's not in trauma because if we have blood, it's very hard to extract. It's for cardiovascular surgeon, but sometimes we can use a parasternal approach or paraapical approach. It's hard for blood, but sometimes we use it in pre-hospital area till we arrive to the hospital. And the last application for emergency in trauma is to identify foreign body and maybe to guide the surgeon or the emergency physician to extract this foreign body. Depending if we see or not this foreign body, because it's depend on body composition. And if we have a stone plastic of wound, we see the shadow. If we have a comet tail artifact, maybe we have metal and glasses like here, or sometimes we see around the foreign body the inflammatory reaction or the hematoma. We can use also Doppler examination, and we see the struggle of, above the foreign body sometimes. In conclusion, this ultrasound help us to have another eye and to know what to do when we have a complex situation in which we need to guide our procedures and to avoid error and also to avoid the complication. And ultrasound represent a real instrument to avoid error and to reduce complication in our daily practice. For us, it's important in trauma patient also with pelvic fracture to use guided of bladder cannulation, because many times we have error and the tube is not into the bladder, it's into urethra or something else. Thank you if you have question.